Hello, I'm Laura Nguyen, and on behalf of all the authors, I will be talking today about electrophysiological monitoring for traumatic brain injury. In this lecture, we will cover methodologies for electrophysiological monitoring, normal and abnormal EEG, examples of epileptiform activity, and spreading depolarizations. There are many methods used for monitoring electrophysiologic activity. However, scalp EEG is the gold standard for detection of seizures in the ICU setting. As recommended by the American Clinical Neurophysiological Society guidelines and the International Federation of Clinical Neurophysiology, the 1020 system should be used to place a standard 21 electrode array across the head. Recording amplifiers typically use filters set to record frequencies from a lower limit of 0.5 Hz to an upper limit of 70 Hz. A notch filter is also used to attenuate 50 or 60 Hz electrical noise. Recording of ultra-slow frequencies, down to the theoretical limit of 0 Hz, is necessary to detect spreading depolarizations, which we will discuss later. This requires specialized direct current coupled amplifiers, and these are not standard for most EEG systems, but are commercially available. Continuous scalp EEG allows full temporal resolution with cortical spatial resolution. Use of cup electrodes placed with gel and colloidin to glue electrodes is safe and non-invasive. In the presence of skull defects, such as in patients that have undergone a decompressive hemicraniectomy, care must be taken in the interpretation, as the defect can cause extenuation of fast activity and increased amplitude of recordings, referred to as breech rhythm. The duration of continuous EEG for comatose patients is often determined by local practice patterns, but a minimum of 24 hours is recommended, and up to 72 hours is a reasonable target based on the time to detection of first seizure. Intraparenchymal electrode arrays can be tunneled through a burr hole or placed through a bolt, as is common for intraparenchymal ICP monitoring. Depth electrode arrays used in traumatic brain injury patients are approximately 1 mm in diameter and consist of 8 1.3 mm long cylindrical platinum contacts evenly spaced. Subdural electrode strips have been introduced for monitoring acute brain injury as the gold standard method for detection of spreading depolarizations. As a sensitive intracranial method that samples a larger, about 5 cm extent of cortex than depth arrays, they are also likely the most sensitive method to detect seizures. The standard subdural electrode strip is a linear strip containing 6 platinum electrode contacts with centers spaced 10 mm apart. Intraparenchymal electrodes require drilling a burr hole for placement, and similar to depth electrodes placed for seizure surgery, they can cause minor inflammation and tissue damage at the site of insertion. They are thus more invasive than scalp EEG, yet have an overall good safety profile. Proper placement of intraparenchymal electrode arrays to target cortical gray matter is critical for the acquisition of usable data. This is achieved by targeting maximal depth of 1.5 cm from the inner table of the skull, so that the most superficial electrode is near the bolt and a subset of electrodes are located within the 4 to 5 mm thickness of the cortex. Preferred placement of subdural electrode strips in traumatic brain injury is in a pericontusional area, with some electrodes spanning the periphery of the contusion and the remaining electrodes on so-called normal tissue. The strip should be aligned along a single gyrus when possible. Subdural electrode strips avoid creation of local tissue damage and inflammation, as they are placed on top of the cortex and not within it, and therefore in some ways are less invasive than intraparenchymal arrays. Special considerations such as attention to bony edges, cranial fixation plates, and having an appropriately wide subcutaneous tunnel for the electrode tail are necessary to facilitate removal of the electrode strips at bedside. Evoked potentials refer to the recording of stereotypic electrical responses to stimuli. Somatosensory evoked potentials can be produced by electrical stimulation of peripheral nerves and record the response at the parietal cortex. Visual evoked potentials can be elicited by flashing lights, and responses are recorded at the occipital cortex. The existence of these signals suggests the presence of peripheral cortical connections that can be useful for prognosis in TBI patients, just as bilateral loss of cortical responses is correlated with coma and poor prognosis in anoxic brain injury. However, there are limitations to the use of evoked potential data, such as difficult interpretations in patients with skull defects and the inability to determine if bilateral loss of cortical responses soon after severe TBI obviates neurorecovery. Currently, data does not support the routine use of evoked potentials in TBI patients for clinical prognostication. Process EEG devices can also be used for monitoring of brain activity, although traditionally these use proprietary algorithms that lack the transparency of direct EEG monitoring. BIS Spectral Index, BIS, includes an algorithm that utilizes power spectral variables, bicoherence, and burst suppression information from frontal EEG electrodes. BIS is typically used to measure the depth of anesthesia during surgical procedures, yet BIS values have been shown to correlate with the GCS score and may be predictive of unsalvageable TBI. There is currently not enough evidence for an international consensus recommendation to support the routine use of BIS for brain injury patients in the ICU. Another EEG derivative is the BrainScope, which is an FDA-approved handheld device that generates a structural injury classifier and brain function index for point-of-care assessment of TBI. It lacks the temporal resolution afforded by continuous monitoring methodologies and the spatial resolution of full-scalp EEG. Yet it has the advantage of being a rapid assessment tool that may show utility in austere environments and in the emergency room as a brain electrical activity biomarker for identification of mild TBI patients. Its use in TBI patients requiring ICU level of care has not been studied. EEG records the aggregate charge of the dipoles created by the excitatory and inhibitory postsynaptic potentials in the area of cortex underlying each electrode. A single epileptiform discharge requires approximately 10 cubic centimeters of synchronously firing cortex. Similarly, large regions of cortex are modulated by a combination of local and distant connections to create the EEG activity seen during states of wakefulness or sleep. On the left is an example of normal background EEG, and the right shows a sample of the quantitative EEG panel, with the vertical line here denoting the area represented by the raw EEG. The posterior dominant rhythm is seen during conscious wakefulness, and is best seen with the eyes closed at rest. When the eyes open, the posterior dominant rhythm attenuates. Here, the posterior dominant rhythm is underlined on the raw EEG. Similarly, the posterior dominant rhythm gradually attenuates as the brain enters the first stage of sleep. On the quantitative EEG, the posterior dominant rhythm is seen as a brightly colored band of higher powered alpha frequency. The lower power blue bands of beta frequencies reflect the presence of sleep spindles. Over time, the sleep and wake cycles of the EEG can be inferred, as labeled. EEG often shows diffuse background slowing, which is a subjective judgment that the EEG appears to be slower than normal. While there is no consensus definition for background slowing, many EEG interpreters consider mild diffuse background slowing to occur when the posterior dominant rhythm is about 6 to 8 Hz, and organization and reactivity are preserved. Moderate diffuse background slowing occurs when the posterior dominant rhythm slows further to 4 to 6 Hz, and there is a loss of the normal background organization but preservation of reactivity or variability. Here is an example of a moderate diffuse slow background. Note the lack of high frequency power on the quantitative EEG panel. Severe diffuse background slowing is typically characterized by a predominance of delta frequencies, which are those less than 4 Hz. and when there is limited or absent reactivity. Reactivity is defined as the change in the frequency content of EEG with stimulation. The lack of reactivity has been associated with mortality. Here is an example of severe diffuse background slowing. Note the lack of power in either the theta or alpha frequency bands. Here is an example of seizures and quantitative EEG showing the typical evolution of frequencies over time with the characteristic flame-shaped appearance. Seizures can also be identified on subdural electrode strips, and often are present when absent on scalp EEG, such as this example in a TBI patient. Here, on the scalp EEG, no seizures are seen. However, the subdural electrode strip captures the seizure. Abnormalities recorded on conventional EEG can be conceptualized as lying on a continuum of potential harm. This is often referred to as the ictal-interictal continuum. Seizures and status epilepticus have the highest potential for inducing secondary brain injury, while non-epileptiform changes in background, such as slowing or discontinuity, likely mark cerebral dysfunction without portending a risk of further brain injury. In between these two extremes, numerous abnormal rhythmic patterns can be identified that both predict the development of seizures and may have potential for promoting secondary brain injury. We will discuss and show examples of some of these abnormal patterns in the following slides. In contrast to seizures, which should show evolution in frequency over time and spread across multiple leads, periodic discharges are rhythmic epileptiform discharges that are static and non-evolving over time. Lateralized periodic discharges are periodic discharges that occur within a single hemisphere. They are associated with focal structural brain injury and are strongly associated with seizures. Here is an example of a patient with right frontal lateralized periodic discharges. This patient went on to develop a right frontal seizure, seen here. The seizure continues here and here, and the seizure stays confined to the right frontal region. In contrast to the lateralized periodic discharges, generalized periodic discharges occur symmetrically across hemispheres. Generalized periodic discharges may occur in response to diffuse bilateral cortical injury, such as after anoxic brain injury, but may also occur in response to systemic processes such as sepsis, acute kidney injury, and hepatic dysfunction that can cause toxic metabolic encephalopathies. Generalized periodic discharges associated with toxic metabolic processes often have a characteristic frontal predominant triphasic morphology and will improve as the systemic stressor resolves. Often termed triphasic waves, these abnormalities are thought to have decreased epileptogenic potential compared to generalized periodic discharges caused by structural brain injury. It is important to note, however, that the unambiguous definition of triphasic waves can be challenging, and that inter-rater reliability for distinguishing triphasic waves from other generalized periodic discharges is not high. Here is an example of a patient with toxic metabolic associated triphasic waves. These triphasic waves improved after improvement in creatinine. Rhythmic delta activity can also be lateralized or generalized. Similar to lateralized periodic discharges, lateralized rhythmic delta activity is highly predictive of seizures. In contrast, the epileptogenic potential of generalized rhythmic delta activity patterns is less clear. The most commonly seen generalized rhythmic delta activity pattern after acute brain injury is that of frontal predominance. Here is an example of generalized rhythmic delta activity with frontal predominance. This pattern, previously called FRDA, may occur in the setting of toxic metabolic encephalopathies or from intracranial hypertension. Another pattern of abnormal electroencephalographic activity seen on continuous EEG is that of stimulus-induced rhythmic, periodic, or ictal discharges, known as SERPITs. These occur in 10 to 22% of ICU patients. Their presence is associated with intracranial hemorrhage, traumatic brain injury, anoxic brain injury, and metabolic disturbances. They often co-occur with distinct forms of epileptiform activity, which indicate an epileptogenic potential of SERPITs. Studies have shown absence of EEG reactivity to be associated with mortality, but SERPITs alone were not independently associated with in-hospital mortality. Here is an example of a patient that showed SERPITs on EEG. Here's the baseline EEG and the response with stimulation. The SERPITs improve as stimulation stops. Electrophysiological monitoring for seizures in the acute setting after traumatic brain injury is warranted for 3 reasons. First, non-convulsive seizures can cause alterations in levels of consciousness and focal neurologic deficits that, if left unidentified and untreated, can lead to markedly worse clinical states. The prompt identification and treatment of seizures may therefore improve overall neurologic status and hasten the process of clinical recovery. Second, seizures may directly induce secondary brain injury through a multitude of mechanisms, including raising ICP, triggering excitotoxicity from excess glutamate release, and creating excess cerebral metabolic demand that cannot be matched by oxygen and glucose delivery, leading to relative ischemia. A more recent study combining intracranial EEG using invasive depth electrodes with cerebral microdialysis in patients with severe TBI showed that both electrographic seizures and periodic discharges that lie on the ictal interictal continuum are associated with metabolic dysregulation. Third, seizures and epileptiform discharges identified in the acute period predict the development of post-traumatic epilepsy. Although the true causation relative of early seizures and development of post-traumatic epilepsy is unknown, the identification of early seizures may allow for more effective risk stratification and monitoring of survivors of head trauma. Another form of abnormal electrical activity, commonly seen after brain injury, is spreading depolarizations. Ion concentrations are tightly regulated in intracellular and extracellular spaces of brain tissue, and pathologic conditions can disrupt ion regulatory mechanisms, resulting in a variety of paroxysmal electrical dysfunctions. While physiological extracellular potassium is 3 millimolars, a rise to about 7 millimolars causes the generation of seizures. At a higher threshold of about 12 millimolars, a fundamentally different type of dysfunction emerges, a paradoxical silencing of brain activity, known as spreading depression. This response is caused by the near-complete breakdown of ion gradients across neuronal and glial cell membranes. The gradients normally maintain a membrane electrochemical potential around -65 millivolts. But during spreading depression, membranes become depolarized to almost 0 millivolts for a period of about 1 minute or longer. This spreading depolarization is observed as a large, slow negative shift of extracellular potential. This short-circuiting of neuronal membranes prevents generation of synaptic potentials and action potentials, resulting in a silencing or depressing of spontaneous electrical activity in the affected tissue. Once initiated focally, the depolarization propagates slowly as a reaction diffusion process at 1 to 9 millimeters per minute through contiguous cerebral gray matter. The spread is mediated by the release and extracellular diffusion of depolarizing factors, such as glutamate and potassium, that sustain a self-regenerative wave. Spreading depolarizations are thus differentiated from both normal and abnormal neurophysiology by several paradoxical features. 1. They represent excess excitation in terms of membrane potential and neurotransmitter release, yet cause a loss of tissue function instead of a gain. 2. They differ from other forms of depressed brain activity such as burst suppression EEG, which are mediated by inhibitory neuronal hyperpolarization. And 3. Being mediated largely by mass extracellular diffusion, they violate the neuron doctrine of precise and fast electrical signaling through electrical and chemical synapses between cellular units. Electrocorticography recording here is showing the co-occurrence of ictal epileptic field potentials with spreading depolarizations. The top traces show raw direct current, DC, recordings from 3 electrodes, and the bottom traces show high-frequency activity from the same electrodes, alternate current, AC. Thus, the bottom traces display the actual spontaneous brain activity resulting from the summation of postsynaptic excitatory and inhibitory potentials. The electrographic seizures, rhythmic 1.7 per second high-amplitude spike activity, are predominantly seen in electrodes 1 and 2. Spreading depolarization is observed as a large negative DC shift, which propagates between different electrodes at a rate between 2 and 9 millimeters per minute. Here, spreading depolarization propagates from electrode 2 to 3. As can be seen, the negative DC shift of a spreading depolarization is significantly larger than that of a seizure. This reflects the significantly more free energy is released during an SD. The intra-extracellular ion concentration changes are significantly larger. The water uptake into the neurons is higher, as in cytotoxic edema, and there is significantly more glutamate that's released, leading to glutamate excitotoxicity. Spreading depolarizations in electrically inactive tissue are denoted with the adjective isoelectric. Isoelectric SDs indicate that there is energy deprivation in the tissue. Consistent with this interpretation, isoelectric SDs were associated with a highly significant 7-fold increase in the risk of unfavorable outcome at 6 months in a prospective observational multicenter study of patients with traumatic brain injury. In the present example, this concept is supported by the observation that spreading depolarizations were coupled to increasingly stronger transient decreases in tissue partial pressure of oxygen, as well as a stepwise cumulative decrease in baseline oxygen. Here, the top traces show the raw DC recordings from 3 electrodes. Middle traces show the changes in spontaneous brain activity at the same electrodes, and the bottom trace shows the changes in tissue partial pressure of oxygen. The initial SDs had short duration DC shifts and depression periods. Thereafter, recovery from depression periods is only partial until spontaneous activity is completely and persistently depressed, i.e. isoelectric. Development of isoelectricity occurs progressively as a consequence of SDs, as evidenced by DC shifts propagating between the different electrodes. SDs were coupled to increasingly stronger transient decreases in tissue partial pressure of oxygen, as well as a stepwise cumulative decrease in baseline oxygenation. Spreading depolarizations can be triggered in gray matter experimentally by various noxious stimuli, including electrical, chemical, or mechanical stimulation. Thus, they also occur spontaneously as a response to ischemia, hemorrhage, and traumatic injury. Understanding of the pathologic role of depolarizations is derived mainly from studies of focal cerebral ischemia, which have established the concept of the spreading depolarization continuum and the causal role of depolarizations in lesion development. After onset of arterial occlusion, depletion of energy reserves causes an initial mass depolarization of affected tissue after 2 to 5 minutes. This depolarization persists indefinitely within ischemic tissue, since recovery, repolarization, is energy dependent, requiring ATP to pump sodium and potassium across membranes against their electrochemical gradients. This persistent depolarization establishes the hallmark features of the ischemic core, including cytotoxic edema, loss of ion homeostasis, and release of neurotransmitters. The same wave, however, also spreads beyond the core, through the penumbra and into healthy tissue, along a gradient of increasing blood flow, oxygen, and glucose. Accordingly, the duration of the depolarization becomes shorter along this gradient, reaching the minimum duration of about 1 minute, as observed in normally perfused tissue. The continuum thus describes variations in duration among this class of waves from persistent to briefly transient, and also their dependence on the baseline metabolic state. The continuum further describes the gradation of effects on tissue, which vary from infarction in the core to transient benign disturbances in normal brain. After the initial wave, further spreading depolarizations continue to recur spontaneously for hours to days after stroke onset. These arise as a consequence of energy supply-demand mismatch in the ischemic penumbra and mediate time-dependent infarct growth, or so-called secondary injury. The spread of these depolarizations to the infarct border is thought to trigger persistent depolarization in further tracts of tissue, thereby expanding the core and may damage other tissue through excitotoxicity and cytotoxic edema. A final concept that is central to these pathologic effects concerns neurovascular coupling. While spreading depolarizations induce a strong hyperemic response, vasodilation, of local cerebral blood flow under physiologic conditions of intact neurovascular coupling, under pathophysiologic conditions of impaired coupling, they instead induce the inverse response, vasoconstriction, of spreading ischemia. The variation from hyperemia to ischemia is another manifestation of the continuum. Depolarization-induced spreading ischemia accelerates deterioration of the ischemic penumbra and enables growth of the terminally depolarized ischemic core. We will illustrate this in the next example. This figure demonstrates the continuum from the normal to the inverse hemodynamic response to spreading depolarization in 2 patients. These examples are from patients with aneurysmal subarachnoid hemorrhage. However, this continuum has also been found in patients with traumatic brain injury and malignant hemispheric stroke. The blue tracings show electrocorticography from subdural electrodes, while the red tracings represent regional cerebral blood flow changes measured with laser Doppler flowmetry. In normal tissue, spreading depolarization triggers spreading hyperemia to match the increased energy demand and to clear the extracellular space from metabolites. This is the normal hemodynamic response. In tissue at risk for progressive damage, spreading depolarizations can induce severe hypoperfusion instead of hyperemia due to inverse neurovascular coupling from induced tone alterations in resistance arterioles. This is called spreading ischemia, as seen here with the inverse hemodynamic response. In parallel, the spreading depolarization-associated cytotoxic edema becomes prolonged. The longer lasting the individual spreading depolarization and cytotoxic edema, the higher is the likelihood that neurons die. The flow decline leads to a repercussion of the negative DC shift, which becomes longer lasting compared to the one in normal tissue. In conclusion, recent advances in EEG technology, such as use of computerized algorithms for the quantitative analysis of EEG and the use of intraparenchymal and subdural electrode strips, allows for detecting injury-related abnormal physiology, such as non-convulsive seizures and cortical spreading depolarizations. The use and interpretation of continuous EEG and intracranial electrocorticography does remain highly labor-intensive. There is currently no level 1 evidence that treating epileptiform abnormalities, non-convulsive seizures, and spreading depolarizations can improve neurologic outcome after TBI. However, clinical studies continue to accumulate evidence that electrophysiologic monitoring can guide patient management. Thank you.